Welcome to PCR London Valve 2025. My name is Francesco Saia from Bologna, Italy, and I have the pleasure to be with Tiffany Patterson from London, UK, and Philippe Généreux from USA to discuss the clinical and economic benefit of early intervention in patients with asymptomatic severe aortic stenosis. Let's start with Philippe. Philippe, this year there were a lot of novelties in terms of data, evidence, guidelines about this patient population. What can you talk about this?
Well, first of all, thank you so much for having us. Indeed, 2024-25 was very rich in new data. First of all, the early TAVI trial was the largest randomized trial comparing a strategy of early TAVI to clinical surveillance for 901 patients with severe aortic stenosis and no symptoms. And actually, this trial showed the benefit of an early intervention strategy compared to clinical surveillance in terms of death, stroke, and unplanned cardiovascular hospitalization or heart failure. That on top of the 3 prior randomized trials also showing some sort of benefit in terms of mortality, stroke, or heart failure, led to a change in the guideline, the European guideline in Madrid, that elevate TAVI as an option like surgery for patients with severe AS no symptom as a class 2A, level A, which is the highest level of evidence based on the 4 randomized trial and the meta-analysis. So somehow great news for our patient. Now TAVI is an option for patients with severe AS no symptoms.
Yeah, so strong evidence, clinical efficacy. What can you tell about economic issues?
Well, one of the remaining questions is it cost effective or cost dominant to intervene earlier and not to wait for symptom on those patients? So at PCR London Valve 2025, we present for the first time a model, a Markov model, on early TAVR in terms of the rate of death and the rate of heart failure hospitalization and AVR. And we model the cost effectiveness of early intervention compared to surveillance. And we showed that early intervention was cost effective, also cost dominant, meaning that it was saving money compared to waiting for symptom in 9 countries in Europe. So it was dominant, meaning saving money in across all geography, which I think is very important, especially when we talk about implementation and in countries. Some people may think that doing all those patients, treating all those patients with no symptom may increase the economic burden on centers or on society. As a matter of fact, it's the opposite. Care avoidance costs money on long term. It's always better to be proactive to not only improve outcome for patient, but also improve cost and resource use for society.
Yeah, that's absolutely important information to have. And Tiffany, how do you think this will or should translate into your clinical practice in the UK?
Well, I think Philippe has demonstrated that the data are really clear. We have to do something for clinical benefit for patients, and it's cost effective. And within the UK, we work within restraints. So we really have to look to change our pathways, change mindsets, and really get our hospital infrastructure and management team to understand that they need to make these changes. We need to expand our services and also reach out into the community so that we're detecting these patients earlier, encouraging referrals earlier, and surveying them and keep them under surveillance, ready to act as soon as we're able. I think that's the most important thing, and that will prevent heart failure rehospitalizations down the line, which is really important in terms of cost saving as well as most importantly benefiting the patient.
So big change should happen. Philippe, some practical advices for your colleagues. In clinical practice, what should we do?
So after we digest early TAVR and all those data, I think what we realize is it's time to be proactive. It's time to get early referrals. So as soon as a patient has moderate or severe AS with no symptoms, send them first, refer them early, get their testing, CAT scan, left heart cath if you need, get your teeth fixed, dental clearance before symptoms occur, so we can be ready ahead of time. If patients have symptoms, you should be able to treat them within a month of symptom initiation to mitigate mortality or waiting list. So I think the overarching rule is to be very proactive, like you mentioned, with those patients, to refer them early as moderate, redo the echo, follow them, and as soon as they're severe, you can treat them. And if you start earlier in the game and you get the test done, you will be able to be very efficient, improve the patient outcome, and also save money in the long run. So it's all about proactivity, and I think we have to change this dogma that waiting is okay until the patient fall apart, where now we start the clock of the preparation for the procedure, etc., where we waste time and then it costs money as well.
Well, thank you both for your insight. I think change the dogma is a great sentence. I think we have learned that early referral of patients asymptomatic with severe aortic stenosis have a clinical benefit and an economic benefit. So on this basis, we should be more proactive, promoting detection of these patients, screening, detection, and early referral, possibly to receive early treatment, but if not, to be ready to receive treatment as soon as deemed appropriate for these patients. So thank you very much.